welcome you to the stage.
Thank you very much. Good morning, and thank you for the invitation to give the talk. So yeah, let's just move back to the first slide. All right. So the topic is about cancer and stroke. I don't know if you've seen these cases often in Vietnam, but we see them more and more these days. So my name is Nitya Sumanwala from Bangkok, Thailand, and I'm working at the Chulalongkorn Stroke Center. So today the topic is about cancer and stroke, so I just want to tell you why is it important, and then move you through the pathophysiology of this disease, and then diagnostic approach, and then management, and finally about the prognosis. So starting with why. Cancer and stroke has become quite common, at least in some part of the world. It is found that around 5 to 10% of patients with acute stroke would have some cancer history. And in these cases, the recurrence rate is much higher than the normal, the regular stroke cases. And the mortality is very high. 30-day mortality is around 25 to 50% in these cases. So talking about cancer and stroke, there are some special types of cancer which are related to stroke. Mainly they are adenocarcinoma, maybe from the lungs, from the pancreas, or some of the GI malignancy. Others will be hematological malignancy and head and neck, and some other tumors. At our Faculty of Medicine at Chulalongkorn University and the King Chulalongkorn Memorial Hospital, we kind of have some collection of the data. And this is what we found in around 1,000 cases of stroke. 14 of them would have any history of cancer in the past. And then around 6% of them, 61 cases, had active cancer. 4% of them already have the known cancer, but 20% of them just have newly diagnosed cancer after they are diagnosed with stroke. The most common cancer type is lung cancer, followed by GI and gynecological cancer. Breast cancer, it can be found in some of them. And these are the general stroke patients. But if you look at the younger patients, we have another cohort of younger stroke cases who are younger than 55. You can see that the rate of cancer is much lower, but the type of malignancy is different. You see that ovarian cancer accounts for vast majority of younger cases, and followed by lung cancer. So this is from our data. Next is about the pathophysiology of cancer-related stroke. So for patients with cancer, there are several mechanisms that can be related to stroke. The first and the most important one is the hypercoagulable state, which can be found in cancer patients. Next one would be the direct invasion of the cancer. Sometimes you have cancer in the neck and it invades the artery in the neck or in the brain. The next one would be the other non-hypercoagulable state related to stroke. Maybe they would have some stress-related cardiomyopathy or some other diseases. And lastly, it's related to the treatment. Many treatment can cause, for cancer, it can increase the stroke risk, and some of them may even cause a stroke. Going to the most important one, which is the hypercoagulable state. So the mechanism of hypercoagulable state in these cases can come by different mechanisms. The first one is the activation of the coagulation cascade. Tumor itself can release factors like tissue factors, plasminogen inhibitor to activate the clotting system. The next one would be the platelet activation. The third one, which is also very important, is what we call NETs, which is a neutrophil extracellular traps. Increasing neutrophil and some activation in cancers can cause more hypercoagulable state and clot forming in the artery. It can also relate it to the NBT, which is a non-bacterial endocarditis, and in some cases with solid tumor, they can have anti-phospholipid antibody as well. So for extreme case, we have the hypercoagulability, which is called Trousseau syndrome. In these cases, they would have cancer and they would have migratory thrombosis over the different part of the body. And then for the brain, they can have multiple emboli multiple cerebral infarction. And these are mainly related to mucin-producing tumors like pancreatic tumor, lung tumor, cancer, and GI tumors. And in these cases, we can, if we suspect a tumor, we can look for it by measuring the D dimer in the bloodstream. And this is a big clue for diagnosis cancer and in patients with stroke. So NBTE is the non-bacterial thrombotic endocarditis. It can be related to some autoimmune disease or some cancers. So this is like fibrin and platelet vegetations at the heart valve, and this is related to hypercoagulability. And it can cause multiple emboli to the brain. And this is an example of a case who presented with right leg weakness. This is a lady who had acute stroke, and then we can see that she has anterior cerebral artery infarction. But for the MRI, you can see that she had other multiple infarct in the cerebellum as well, and on the other side of the hemisphere as well. SWI shows some bleeding in the brain too. Her D dimer was 9,000 something, and she also has history of weight loss during the past month, 10 kilograms. So this points to some underlying disease, not just the regular cases of stroke. So we did that whole abdomen CT scan, which found that he had cholangiocarcinoma in the abdomen. So we believe that this is related to her stroke. Another case of adenocarcinoma of the lung and multiple sites of stroke. You can see multiple small areas infarction, and the lung cancer can be found in the chest X-ray. And this is what we call thrombotic NBTE, the non-bacterial thrombotic endocarditis. You can see these little things in the aortic valve. This is related to hypercoagulable state in cancer patients. So that's the first one, cancer-related hypercoagulopathy. So we can have direct tumor effect, like tumor in the neck can compress the artery itself. So this is kind of straightforward. We can have some iatrogenic effect of the treatment. In some cancer treatment, like chemotherapy, the VEGF inhibitor, like some of them, or some other platinum-based agents, can increase ischemic stroke risk. Also, there are some new medications that also can increase the risk of atrial fibrillation and also increase the risk of stroke. In our Asian population, radiation therapy can cause vasculopathy, mainly the radiation of the head and neck area. We see a lot of nasopharyngeal cancer patients, right, having radiation over at the neck, and they become having the carotid stenosis later on, 7 years, 10 years later, and causing a stroke. Also, the immunotherapy can increase the risk of stroke as well. So what about the diagnostic approach? So when you think about these patients, we are mostly neurologists, so we see stroke patients who come in. If the stroke patient is coming in and they have recurrent stroke within a short period of time, or they have multiple emboli in the brain, these are the real clinical clues for diagnosis of probably cancer-related stroke. Other clues would be in the history of illness, like having weight loss, fever during the past couple months, or active cancer in the history. So these things would point you to be thinking about the cancer-related stroke. So then you would need neuroimaging. I would suggest MRI, which is more sensitive, to look for small lesions in the brain. And then maybe you have cardiac evaluation if you can see that there are multiple emboli in the brain. And then the lab assessment. The most important lab to me is the D dimer. So to check the D dimer, if it's very high, it's very suspicious of cancer related. And then you can look for other markers and vascular evaluation. And search for malignancy. We would do CT, whole abdomen and chest to look for malignancy, and some blood tests, and then think about the treatment. So as I said, clinical context is very important. Multiple stroke in the different territory, history of cancer, history of weight loss, or some systemic illness would point to cancer. And then neuroimaging pattern having multiple emboli like this. So there's one study looking at patients with cancer and stroke. In what group? 50 patients. Control with patients with stroke only, and active tumor cases. So they control, they compare these groups between the blood tests like D-dimer and other tests, and also the transcranial Doppler looking at the microembolic signals. So what they found was that D-dimer is very sensitive and quite specific. So in patients with cancer and stroke, D-dimer can be very high. We have patients who had D-dimer of 20,000 something and active cancer. Stroke patients can have a little elevated D-dimer as well, but not that as high as the ones with cancer. But cancer-only patients, they can have like a little bit of higher D-dimer as well. But if they have cancer and stroke, the D-dimer can be very high, especially those with mucin-producing tumor. And other tests which can be done besides D-dimer. You can test for P-selectin, ICAM family, and also microembolic signal. Just monitor the transcranial Doppler, and you can see, because the emboli goes very often, so you can see these microembolic signal, but they're not related to the recurrent stroke. So there's a description of 3 territory signs where you see multiple emboli. This is MRI of the brain, seeing multiple emboli in both hemispheres and also in the posterior circulation. So see multiple emboli can be a signal of cancer-related stroke. What about management? For management, when you think about acute stroke management, you think about IV thrombolysis, thrombectomy. Though this should be done case by case, according to the guidelines, the American guidelines says that if you have active intracranial, intraaxial neoplasm or GI cancer with bleeding, you should not give IV thrombolysis. The ESO guidelines are not that strict, but practically, I think when you have a patient with suspicious of cancer and need to give IV thrombolysis, you have to think a lot. You need to wait for the lab result before we give IV thrombolysis. Because most of the time we just give IV thrombolysis without waiting for the lab. But in these cases, maybe waiting a little longer. And then check for medications, check for the procedures in the past, and also if the patient is having high risk of brain metastasis, you have to look at the CT scan more carefully and assess for the GI bleeding. For endovascular treatment, I think it's okay to do endovascular treatment in these cases, and we do that all the time with cancer patients. But the challenges would be the outcomes. Since these patients have their life expectancy a bit lower than other stroke patients, so these are things to think about. This is an example of a case, a 39-year-old female who presented with right hemiparesis and aphasia. So she had MCA occlusion on the left side, as you can see here. So we did thrombectomy, and she did well after the treatment. She also has recurrent epigastric pain for a couple of months, and it was thought to be like dyspepsia. So 3 days later, she developed another stroke on the right side. The same patient having a big stroke, left side and the right side after thrombectomy. So we did the MRI, and we found that she had multiple lesions in the brain. So this points to the stroke related to cancer, and she actually had, cancer of pancreas, causing hypercoagulable state and this devastating stroke. For secondary prevention after an acute stroke, we should think about hypercoagulable state, and all of you may think about maybe we should give antithrombotic agents. But according to the studies which we have listed here, the result is kind of controversial. I think the mechanism would point us to give anticoagulation, but the evidence is not there. In the ESUS studies comparing the NOAC and antiplatelets, still in patients with ESUS history of cancer, in Navigate, ESUS, and Arcadia, the result is still negative. So there's no real evidence of giving anticoagulant in these cases. So still unanswered question whether we should give anticoagulant or antiplatelet. Anyway, the life expectancy of these cases are not that long, and also they have tendency of bleeding in some other parts of the body anyway, so the risk is there. So lastly, about the prognosis and the care. So in these cases with cancer-associated stroke, they have high risk of recurrent stroke. So this is risk of thromboembolic event and death. So you can see that cancer plus stroke has much higher risk than cancer only and stroke only patients. And as I mentioned from the beginning, that the mortality in 30 days is reaching 50% in some cases. So these are very severe cases and high risk of mortality. So multidisciplinary team approach would be very important because you need oncologists, neurologists, and other team to take care of the patients. So in summary, I just want to mention to you that cancer and stroke cancer can be related to stroke, and you should think about cancer in some stroke cases with some red flag signs, with some history of cancer or history of weight loss or some unexplained systemic illness. You'll have to look for it. Imaging is the clue, and also the lab, especially D-dimer, would be the clue for diagnosis. And then you have to think about the treatment, balancing between the bleeding risk and the risk of having a stroke. And then in long term, the prognosis is not very good. So we need a team to take care of these patients. Thank you very much.
Thank you very much. So we